So when I was given this topic, I thought it is simple. It's a one-day job. I will start a day before and will complete. But I have been preparing this presentation for last a month or so, and still I will say it is not complete. The only certainty about this topic is that, or about this definition is that we just know that hypoglycemia is low blood sugar, but how low is critical for a baby, or how critical a low sugar can be detrimental to a baby's future is still largely unknown. So in the next 30 to 40 minutes, I will be discussing this topic under the following headings. We'll first try to understand that why babies are prone to have low sugars. We'll try, although we will not be able to give a clear-cut definition, but we'll try to define hypoglycemia. Then we'll also go through what all babies should be screened for hypoglycemia, what are the various modalities of its diagnosis, how should we manage once we have diagnosed hypoglycemia, and finally, what are the various markers which can help us in prognosticate such babies. Now, why we are concerned about glucose in a newborn is because the brain primarily utilizes glucose as a source of energy, and there are no energy stores available in the brain. So whenever the blood glucose goes down, it leads to decreased sugar in the brain, and if it is not corrected promptly, it leads to insult to the neurons, which has long consequences, both immediate as well as long-term consequences, leading to impaired neurodevelopmental outcome. Also, it is a common condition for which babies are brought to the NICU, and it constitutes about 5 to 10% of admissions in term and around 15 to 20% admissions in preterm. Babies who are at risk are more prone to develop hypoglycemia, and it has been seen at least half of them go on to develop hypoglycemia, and around one half of them go on to have recurrent hypoglycemia, that is more than one episode. As we go further, we need to understand the metabolic transition. Quite often we discuss about the respiratory and the cardiovascular transition, but we often fail to talk about metabolic transition and give its due importance and try to understand it. So once the fetus is inside the womb, he gets a continuous supply of glucose from the placenta, and he is a bystander. He doesn't have to act. And there is a continuous supply of glucose running from placenta to the baby, just like an IV line. Now what happens is that once we cut the cord, we break this chain of continuous supply of glucose. So now baby is almost starved. That is, it is like a fasting state for the baby. In order to establish a successful transition, the body has to undergo certain mechanisms, and the success of this transition depends on activation of various regulatory hormones or processes, which mainly include glycogenolysis, where glycogen is broken down into glucose, or formation of glucose from other substrates like amino acids and free fatty acids, which is known as gluconeogenesis, or production of ketones. Remember that ketones is one of the alternate source of energy to the brain cells or neurons. Any baby who fails to establish these processes tends to have low blood sugar and constitutes hypoglycemia. Now, the research for hypoglycemia has been going on from decades. Various researchers have tried to define what is hypoglycemia, or what is the important cutoff, what is that magical number which can be taken into consideration for management of hypoglycemia and preventing brain injury. Now, the first definition, as often is seen in medical literature, is the statistical definition, where we take a cross-sectional data, we try to see the normal range in the population, and then we define what is median, what is IQR, and then based on that data, we extrapolate and give the normal values. Same is true for blood sugar. When the scientists tried to give a statistical definition of hypoglycemia, they found that a median of 54 milligrams per deciliter with an IQ of 41 to 60. Now, once we apply this definition to our babies in day-to-day practice, the problem is that this data was taken from babies without initial feeding. Also, this was a cross-sectional data. And if we go by this definition, then we will have to admit almost 20 to 40% of babies to our NICUs, start them on IV glucose, prevent them for establishing early breastfeeding, and separate the baby and the mother. So this is not going to happen, and this is not the way to go. So scientists thought of defining it clinically, just like we define it in children and adults. That is something known as Whipple's triad, which is used to define hypoglycemia in children and adults. Now, what is this Whipple's triad? It is that we should do a blood glucose if it is low, and there are signs and symptoms which are suggestive of hypoglycemia. And finally, when we give glucose or we provide glucose to the patient or to the baby, the symptoms should abate. Now, the problems with this definition when applied to the neonatal population is that majority of the babies who have hypoglycemia, they are asymptomatic. So by this definition, we will not be able to pick up majority of the babies. And the symptoms which are suggestive of hypoglycemia, they are non-specific. There are so many conditions which can mimic signs and symptoms suggestive of hypoglycemia. Also, the level at which the neuroglycopenia occurs, or the level at which the injury occurs to the neurons, may be much lower than that required to cause symptoms. So this definition also is not valid. So we move on to the next definition, that is physiological definition. Just now we discussed that for a successful transition, there needs to be a good level of counter-regulatory hormones like catecholamines, glucagon, growth hormone. So why not apply a physiological definition? Now the problem with this definition is, for diagnosing hypoglycemia, then we will have to do a whole battery of tests. We will have to test for free fatty acids, glucagon, growth hormone, and it is not available at every place. And even in the best of the centers, including ours, if we order these investigations, it will take days to come. So we cannot wait for days for treating or managing a patient of hypoglycemia. Also, the response, the physiological response, will vary from a baby to baby, and it is largely different when we compare term with preterm babies. So this definition also fails. So now, after discussing so many definitions, the researchers came to the point, let us leave this topic, let us not go behind the magic number. Let us define a level below which we should start treating, and we should start thinking that this baby, if the level goes below that level, then it may be injurious. And this was known as operation threshold. So presently, we do not have a single cutoff, but we have a range or an operation threshold where we believe that if the levels go below this cutoff, it may be detrimental, but we are not pretty sure about these numbers. So the various bodies have given various cutoffs. The most important or the most commonly followed definitions are given by the American Academy of Pediatrics and the Pediatric Endocrine Society. In this diagram on the lower side of my screen, you can see that there are various ranges depending on the age. That is, we have a different cutoff for first 4 hours, then 4 to 24 hours. Why so? It is because once we cut the umbilical cord, the glucose level shuts down. So there is physiological hypoglycemia. The levels will go down, and we should not treat these physiological hypoglycemic episodes occurring in the first few hours of life or first few days of life. Because this happens because the cutoff for stopping the insulin secretion are totally different in a fetus and a newborn. In fetus, the cutoff to stop the secretion of insulin is very low. That is, the glucose should go very low, below 20. Then only the insulin secretion will stop. So once the baby is born, the cutoff has to rise. That is, the insulin secretion should stop at levels of 30 to 40. But this doesn't happen in every baby. It takes some time. Physiological studies have shown that it takes 24 to 48 hours for this switch to occur. So we have a different cutoff for different ages or different hours of life, especially for first 48 hours, because these days are the days of transition, and some hypoglycemia is bound to occur. So for first 4 hours, the cutoff given by AAP is 25. Then we have 35 for 4 to 24 hours. And then for day 1 to day 2, we have 45. And beyond 48 hours, we have cutoff of 60. The Pediatric Endocrine Society, whose definition is based on the endocrine milieu, gives a slightly higher cutoff. But the take-home message for this from this slide is that any level which is less than 45 milligrams per DL beyond first 2 days of life should be considered as hypoglycemia. Whereas in babies who are high risk, like certain genetic syndromes like Beckwith-Friedman, Soto syndrome, or a previous family history of hyperinsulinemia, in those high risk babies, a cutoff of 60 should be taken. Now, when these two definitions were compared, the problem with Pediatric Endocrine Society is that if we follow these high thresholds, then majority of the babies will be overdiagnosed, and 30 to 40% of the babies will get admitted to our NICUs. There will be separation of mother and baby. The breastfeeding may fail, and there will be multiple pricks happening because we want levels more than 60 to 70. But the advantage with Pediatric Endocrine Society definition is that babies who tend to have congenital hyperinsulinemia, they tend to get detected earlier with this definition. So Pediatric Endocrine Society definition is not a good definition because it leads to overdiagnosis of hypoglycemia, leading to more number of NICU admissions. And the studies have not shown that by following this higher cutoff definition, we are going to benefit the baby in the long term. Recently, the Canadian Pediatric Society came up with their own upgraded version of guidelines. And for the first 72 hours, they give a cutoff of 47. And beyond 72 hours, they give a cutoff of 60. That is, we should try to maintain levels above 47 in first 3 days and above 60 subsequently. And we should investigate only when the levels go below 50 beyond 3 days of life. Now, is there any evidence for deciding this magical number of 47? Yes, there is. Recently, there was a trial published in Journal of Pediatrics where the researchers tried to study the blood glucose levels in the initial 5 days of healthy term babies. This study studied 67 term infants with a birth weight of 3.5 and mean gestation of 40 weeks. What they observed was quite gratifying. They observed that the 50th centile of these babies was 47 milligrams per DL. Also, they found that the mean plasma glucose was 59 milligrams per DL, and it takes 2 to 3 days for babies to achieve sugar levels which are similar to those in children and adults. And if we take this definition of less than 47 milligrams per DL as hypoglycemia, then in the initial 72 hours, the diagnosis of hypoglycemia will range from 10 to 25%. They also observed that the early term babies, that is babies who are born between 37 to 38 weeks, had lower mean glucose levels compared to those who are born term. And the initial 4 days, babies to the tune of 40% will have at least one episode of hypoglycemia, which is defined as sugars less than 47 milligrams per DL. So keep this point in mind that 40% of term healthy babies without any risk factors will have a sugar episode of at least one episode of sugar less than 47 milligrams per DL. That is what is known as transitional hypoglycemia. And these babies, unless they have some additional risk factors like sepsis or any other subsequent risk factors, they do well with feeding. We don't need to be standing with them with an IV line and start dextrose. It can be harmful, which we'll discuss in subsequent slides. The next study, which was again published recently in NEJM, considered babies who are at risk of hypoglycemia, whereas the previous trial, all babies were without risk, full-term, healthy babies. This trial had almost 700 babies who were at risk, like IUGR, HGA babies in front of diabetic mothers. These babies had a mean gestation of 35 weeks and weight was around 2 kgs. They compared two thresholds, that is, whether a sugar of less than 36 versus less than 47 makes any difference in the first 48 hours of life. And the primary outcome they studied was neurodevelopmental outcome at 18 months. And what they found was that there is no difference whether you follow less than 36 milligrams per DL or less than 47 milligrams per DL as cutoff for treating hypoglycemia. Also, the good thing was no infant in either arm developed symptomatic hypoglycemia, but there were certain problems with this trial, and it cannot be generalized to the whole population. It was, first of all, a non-blinded trial. Only at-risk babies were included, and babies who had severe hypoglycemia, that is glucose of less than 35 milligrams per day, were excluded. And they did not give a detailed analysis of the blood glucose level present in the two arms. And also we know that 18 months is quite a short time to study neurodevelopmental outcomes, be it HIE or hypoglycemia, or for that matter, any other brain injury. Coming to the clinical features, the clinical features can be protean. The baby can be totally asymptomatic and it can be diagnosed on just routine screening. When we come to the symptomatic babies, it can be largely divided into two types. The first one is autonomic features, which are because of the activation of the sympathetic system as a compensatory mechanism in the body. And these are the initial symptoms to occur. And these include, just like any autonomic response, tachycardia, pallor, hypothermia, tachypnea, vomiting, irritability, and jitteriness. And once the glucose in the brain goes down and constitute neuroglycopenia, then we see various CNS symptoms, which can be apnea, lethargy, cyanosis, stupor, or seizure. But what is to be remembered from this slide is that clinical symptoms do not correlate with blood glucose levels. That is, do not be disguised that if the baby is asymptomatic, he cannot have severe hypoglycemia, or do not wait for the baby to throw a seizure to start treating hypoglycemia. The levels are totally different from clinical features and there is no correlation between the two. Coming to the risk factors are important because we should know what are the risk factors. So accordingly, we can strategize our screening policy. Any condition which leads to increased demand of glucose, or there is inadequate supply, or there is altered counter-regulatory hormone response to hypoglycemia constitutes a risk factor for hypoglycemia, and all these babies should be screened, especially in the first 24 to 48 hours. Now, coming to the conditions which lead to decreased glucose supply, the common conditions which we see in our day-to-day care is prematurity and IUGR, because they have low glycogen levels, and glycogen is the first metabolite to get breakdown to glucose in order to raise the glucose levels. Also, the demand for these babies is high because of the relatively large surface area of brain compared to the body. Then any defect of metabolism which hinders production of glucose from glycogenolysis or glyconeogenesis will lead to hypoglycemia. Increased demand can be seen in conditions like asphyxia, sepsis, polycythemia, and there are various syndromes like Beckwith-Wiedemann which can lead to hypoglycemia. Majority of the studies have shown that the risk of hypoglycemia, that is 90% of the babies who are going to have hypoglycemia, will tend to have hypoglycemia in the initial 12 to 24 hours for LG or infant of diabetic mothers. So LG and infant of diabetic mothers should be screened for first 24 hours, and subsequent screening should only be continued if the glucose levels continues to be low. Whereas babies who are IUGR and SGA, they tend to have slightly protracted course and they can develop hypoglycemia for the first 2 days. So the screening should continue beyond 24 hours for day 2. And then if the glucose levels are normal, we can stop screening them after 48 hours. Coming to the various devices which are available with us for monitoring hypoglycemia, the first and foremost is the point of care testing, that is glucometer. Although it is easily available, user friendly, but there are inherent problems to this device and this method. Ideally, these devices were manufactured to detect hyperglycemia in adult patients, that is patients who are diabetic. They were designed for adult patients for hyperglycemia. Therefore, they tend to give inaccurate values at sugar levels which are below 50. And remember, our cutoff is around 50 only. So these are totally unreliable to detect hypoglycemia. The variation can be to the tune of 5 to 20 milligrams per DL. So imagine that if the error is 20 milligrams per DL and your glucometer showing a reading of 60, and you are assured that your baby is euglycemic, whereas the sugars may be 40. Similarly, if the sugar level in glucometer is 50, the actual level may be as low as 30, and we are staying relaxed in our NICU that baby is euglycemic. So it can be false reassuring. They have less accuracy, and they act by releasing hydrogen peroxide, which then generates electrons, and then that current is picked up by the electrode and gives a number. Also, one of the common faults which our nurses or our fresh residents do is that they prick on the back of the heel, that is, they prick on the calcaneum. That's not a good method of doing a heel prick, because it has been shown that the repeated pricks at the calcaneum can lead to osteonecrosis, and there is a nerve, and it is quite a painful procedure. So whenever you are doing a heel prick, it should be done on the lateral sides of the foot, as shown in the picture. Now, then what is the method of choice? The glucose electrode system is most reliable because the standard error of estimate is only as low as 3 milligrams per deciliter. It is not affected by bilirubin and hematocrit levels, and therefore remains the method of choice. Therefore, whenever we have a glucose reading which is suggestive of hypoglycemia on glucometer, we should always confirm it with a lab value. But we should not wait for the lab value to come to start treatment. The treatment should be started immediately after sending the sample. Now, the common fallacies with these tests are that arterial blood glucose tends to have high glucose levels. Also, the squeezed sample does not give an accurate result. If we do not wait for the alcohol to dry, again, it can lead to high glucose levels. And remember, once the sample is sent to the lab, it should be processed immediately, because if we delay, the blood sugar levels are going to fall. And hematocrit has an important role to play, because higher hematocrit tends to give low values. And remember that the initial 12 to 24 hours is the time period when there is physiological polycythemia. So unless and until you take care of these, the results are going to be fallacious. Also, bilirubin levels do interfere with the sugar levels. Again, the bilirubin is a common problem in the initial first 3 days of life. So all these conditions should be taken into consideration when considering or treating a patient with hypoglycemia. A word about continuous glucose monitoring, because it is the recent trend or the recent means of measurement of blood glucose in various studies, although this has not taken up in neonatal population, but we should know something about it. It is usually placed on the lateral side of the thigh. It has got a sensor which goes deep into the subcutaneous tissue, and the glucose which diffuses from the vessels shown in the red here is picked up by this electrode and then transmitted to the sensor to give a continuous value. The sensor is usually consists of an electrode which is usually made up of gold plated. Then it has an enzyme layer which is glucose oxidase, and then there is a semi-permeable membrane covering this glucose oxidase layer. Once the blood seeps through this semi-permeable membrane, The glucose oxidizes this glucose into hydrogen peroxide, and this peroxide then releases electrons, which is picked up by these electrodes and generates a current, and this current is continuously transmitted into a number, and we get a continuous measurement of glucose. Remember that this measurement is of interstitial glucose, not a blood glucose level. Now, what are the problems with this continuous glucose monitoring? First of all, it does not give you immediate results. There is a wetting period where the blood should come, seep through the semi-permeable membrane, and then the reading will come. So it takes at least 1 to 2 hours to get the initial reading. It has to be calibrated frequently because here we are not measuring blood glucose, we are measuring interstitial glucose. Then babies who are premature, small for gestation, since they do not have much of subcutaneous fat, placing this electrode is a difficult in those babies. And also there is lack of support that this method is reliable and makes any difference in the long-term neurological outcome. And also this method is still to be validated in our neonatal population. Therefore, the use of continuous glucose monitoring at present is to know about the transition, how transition occurs in the baby. We can better understand with the help of continuous glucose monitoring. Also, it is a research tool as of now and should not be used in day-to-day practice. Now, as is always said that prevention is better than cure, so we should always try to prevent hypoglycemia, especially in babies who are at risk of developing so. This can be done with the help of simple, cost-effective practices such as early skin-to-skin care practice or kangaroo mother care, starting early breastfeeding within 1 hour of cesarean section or within 1 to 2 hours or within half an hour of normal vaginal delivery. Also, remember that hypothermia is an important risk for hypoglycemia. Therefore, maintaining normal temperature, especially from the delivery room, the warm chain has to be maintained. The delivery room temperature should be set at 26 to 28. We should use warm linen, delay bathing, and ensure skin-to-skin contact. Then there is an upcoming modality known as the dextrose gel, something which our forefathers used to practice. They used to give honey. So this is now the modernized form of honey where we use dextrose gel, although it avoids side effect of contamination and risk of infection. And finally, we should screen babies who are prone to develop hypoglycemia regularly as per our unit protocol. A word about dextrose gel. It is quite useful, non-invasive, inexpensive, and has been found to be safe in various trials. The dose is around 200 milligrams per kg and can be repeated 3 to 4 times. It is applied intrabuccally around the buccal mucosa. And recently, again, in this year only, there was a trial known as HPOD trial, which had around 2,000 babies from 18 hospitals of New Zealand and Australia. They compared 40% dextrose gel versus placebo gel within the first hour of life, and they saw whether it makes any difference in NICU admissions. Although they could decrease the incidence of hypoglycemia with using this gel, but they could not decrease the rate of NICU admissions. However, the good thing was that there were no side effects observed and there was no hyperglycemia. Some of the studies which have tried to look at the long-term outcomes did not find any difference when they compared placebo versus dextrose gel at 2 years of life. So although the incidence of hypoglycemia comes down, whether it translates into any clinical improvement in clinical important outcomes is yet to be seen. Coming to the management goals should be to decrease the chances of neurological impairment occurring as a result of hypoglycemia. At the same time, we should not be overzealous and overtreat these babies, because overtreatment means separation of mother and baby, disruption of breastfeeding, increased cost to the family, and more pricks. Remember that pain in itself is an important prognostic factor for impaired neurological outcome. The treatment when the sugars are borderline should be ensure adequate feeding, early and exclusively breastfeeding. And whenever the levels are borderline, we should ask the mother to frequently breastfeed her child. Once, despite feeding, the levels are not corrected or the patient tends to have symptoms, then we should start with IV dextrose and give a GIR of 5 to 6 milligrams per kg per minute. Remember that a concentration of more than 12.5% dextrose should not be given in a peripheral way, and avoid giving boluses to asymptomatic patients. Giving boluses to asymptomatic patients can be more harmful than hypoglycemia. And for calculation of GR, there are readily available apps, GR charts, which can be pasted in our NICUs so that even the nurses can start the initial treatment. For example, in this GR chart, if we give the fluid, which is shown along the y-axis at 60 ml per kg per day of 10% dextrose, it constitutes a GR of 4.2. And if we roughly increase this fluid by 20 ml per kg, the GR will increase by 1. So these charts should be readily available in each and every place where newborns are being treated. Now, for calculation of the GR or percent dextrose, there is a simple formula which is given in the majority of the common books, ranging from Meherban Singh to Kulharti, where GR, that is glucose infusion rate, is calculated as rate of IV fluids. For example, on day 1, we give 60 ml per kg per day. So here we will have 60 multiplied by with the percent dextrose divided by 144, which remains constant. Whereas if we have to calculate what is the percent of dextrose infused, then GR has to be multiplied by 144. Remember that the initial GR is usually around 5 to 6. So it will be 5 into 144 divided by ml per kg per day, depending on the day of life, 60, 80, 100, 120 or so. Now, if it is 10% dextrose or 25% dextrose, we do not have a problem because we have readily available 10% dextrose and 25% dextrose solutions in our NICU. But what about when the percentage comes in between these two, that is 15, 12, 18%? For that, we have a simple formula, which is where V is stock solution. That is, I have to make 100 ml of the stock solution. Then D is the dextrose concentration, which I want. For example, I want 15% dextrose for my baby. So it will be 15 minus the lower concentration, which is available, that is 10. So it will be 100 ml of stock solution multiplied by D, that is the dextrose, which I want, is 15 minus 10 upon high minus low, which is available with B, that is 25 minus 10. So it will come out to be, suppose my stock solution is 100, I want a 15% dextrose. So minus the lower concentration which is available with me, that is 15 minus 10, divided by high minus low concentration which is available with me, that is 25 minus 10. So it will be 15. So this comes out to be 33 ml. That means I will have to add 33 ml of 25% dextrose to make a 15% dextrose solution. Out of 100, if I subtract 33, the rest has to be 10% dextrose. So this is one of the simplest formula which can be taught to the residents, to the nurses, so that the treatment is not delayed. This is especially important for centers who do not have residents or doctors available round the clock. This is a broad working principle for treating hypoglycemia. That is, for asymptomatic babies, any value which is less than 20 at any hours of age should be started on IV dextrose. Bolus again should only be given when the patient is symptomatic. However, if the levels are from 20 to 45, we should give a trial of oral feeds and then recheck after half to 1 hour. And then if the levels are rising, then we can continue with the frequent feeding and we can avoid IV fluids. However, if the patient is symptomatic or the levels are beyond 48 hours, the levels are less than 45 to 50, then we should again give a trial of feeds. And if the values continues to be low, then we should start a GR of 5 to 6 milligrams per kg per minute, and then check every half an hour till euglycemia is maintained. Once euglycemia is maintained, then we can check the sugar levels after every 4 to 6 hours. On the other hand, if the euglycemia levels are not maintained, we should increase GR by 1 to 2 milligrams per kg per minute and recheck after every half an hour till euglycemia is attained. Now, when to taper? Once the patient is euglycemic for 24 hours, then the GR has to be decreased by steps of 2 every 4 to 6 hours. And once the baby is on GR of 4, we can directly stop IV fluids. Now, one of the important questions which people ask is that should we stop feeding while giving GR, or should we calculate separately GR from feeds or fluids? The simple thing is that first of all, we should understand what is the importance of feeding. Remember that patients or our neonates, they have less ketones in their body, and giving breastfeeds is an important source of ketones. Remember that ketone is an alternate fuel for brain cells or neurons. So the best advantage with breastfeeding is not only to give GR, but also to provide ketones to the body. So whenever there is hypoglycemia, the brain can utilize these ketones as an alternative source of fuel. So unless and until patient is highly unstable, do not stop feeds, continue feeds, and you do not have to calculate GR for feeds. Calculate GR only for the fluids and continue baby on the feeds. So that is the important message from this slide. Why I warned you about giving IV boluses in patients who are asymptomatic is because there is something called as glucose reperfusion injury, just like we see blood reperfusion injury in case of HIE. Similarly, we have glucose reperfusion injury. It has been seen that sudden fluctuations of glucose, that is patients who have hypoglycemia, if they are given boluses and there is a rapid shoot up of the glucose levels, it leads to free radical production. There is activation of neuronal NADPH oxidase leading to free radical injury, causing damage to the cells. Also, there is overactivation of the neuronal PARP1 enzyme, which is normally used for DNA repair. But however, if it is overactivated in the body, it leads to necrotic cell death. Also, in adults, it has been shown that if we treat hypoglycemia with ketones, it is more beneficial and it decreases neuronal brain injury. So please remember that do not give IV boluses if the patient is asymptomatic. It can be more detrimental. Just like fluctuations in blood pressure can be harmful for causing IVH, similarly, rapid fluctuations in blood sugar levels can be important cause of brain injury. And you may be doing more damage because of these fluctuations rather than the hypoglycemia causing the brain injury. A word about persistent hypoglycemia. Persistent hypoglycemia is defined as any hypoglycemia which persists beyond first 7 days of life, or where the rate of infusion is more than 10 to 12 milligrams per kg per minute. Remember that we talked about transitional hypoglycemia. Sometimes, although majority of the babies, they do a successful transition but 4 days, but sometimes it may be prolonged up to 7 days. That is why this 7 days cutoff has been taken. But that does not prevent you for diagnosing or treating a patient as persistent hypoglycemia if there are additional risk factors like patient is apparently syndromic, there are features of Beckwith-Whitman syndromes or Soto syndrome, or there is a family history of hyperinsulinemia. The most common cause of persistent hypoglycemia in a neonate is congenital hyperinsulinemia. And as soon as the levels of sugars go below 50, we should send a critical sample for blood insulin. And if the levels are more than 1, it is diagnostic of hyperinsulinemia. Also, a glycemic response should be there, and it should raise the blood glucose levels by 30 milligrams per dl within 15 to 45 minutes. And also, the requirement of GIR in these babies is usually high, that is more than 7 milligrams per kg per minute. Other causes of persistent hypoglycemia include various syndromes like Beckwith-Whitman, Costello, and Soto syndrome. Therefore, always look at dysmorphism when treating a patient of hypoglycemia, and you may be able to detect hyperinsulinemia quite early and prevent recurrent episodes of hypoglycemia. Whenever there is failure of the counter-regulatory hormones, it leads to persistent prolonged hypoglycemia. Why this is important? Because these babies have high risk of brain injury. And whenever there is any disruption of metabolism, again, it is obvious that it will cause persistent and recurrent episodes of hypoglycemia, and thereby picking up these diseases early is going to be beneficial both in short term as well as long term. Therefore, always ask about history of consanguinity, previous history of hyperinsulinism, look for body proportions, do anthropometry. If there is LG baby, again, most likely these babies can have hyperinsulinemia because of the congenital hyperinsulinemia. Similarly, for Beckwith-Hamilton syndrome, look for omphalocele, organomegaly, ear pits. Now, what is the approach to prolonged hypoglycemia? Once we suspect a baby with prolonged hypoglycemia, we should send a critical sample, which includes a blood gas, insulin, ketones in the form of beta hydroxybutyrate, and free fatty acids. If the gas shows that there is no acidosis and the only abnormality is rise in insulin, then it can be either transitional neonatal hypoglycemia or genetic hyperinsulinemia. How to differentiate both, we'll discuss that in subsequent slides. Whereas if there is increase in free fatty acids, then we should think about fatty acid oxidation defect. On the other hand, if blood gas is abnormal and there is acidosis with increase in lactate, then think of gluconeogenesis defect. Whereas if there is acidosis along with increase of ketones, that is ketotic hypoglycemia with acidosis, think of glycogenosis or other endocrine abnormalities like growth hormone deficiency or cortisol deficiency. Various drugs which are used for management of these persistent hypoglycemia, first and foremost is diazoxide, which can be both diagnostic as well as therapeutic, because there are some mutations which are highly sensitive to this drug. It is used in the dose of 5 to 20 milligrams per kg per day, always used with the smallest dose possible, because this drug is not without side effects. It leads to fluid retention, hyponatremia, and can sometimes cause bone marrow suppression and even hypotension. Other drugs which can be used is octreotide, again, which is a good drug and usually is the second line after diazoxide. If diazoxide alone is not able to control hypoglycemia, the common side effects seen with octreotide is vomiting, NEC, or anaphylaxis. It can be either given as IV infusion or subcutaneous injection, and the doses can, in refractory cases, can be as high as 50 to 60 micrograms per kg per day. Glucagon is not a good drug for long-term basis. It should only be used to tide over crisis. And nifedipine is again a drug which is not commonly used but should be used in babies who are refractory to diazoxide and octreotide. One of the important drugs which I have not importantly included in this slide is steroids. That is, again, steroids should use only for short intervals. And if there is no response within 3 to 5 days, please stop the drug. Otherwise, you are going to cause more problems with continuing steroids, such as Cushing-Goid syndrome, dyslipidemia, dyslipidemia. Steroids have to be again used only to tide over crisis and not as a permanent therapy. Coming to the outcome, which is something which we are always interested. Not only we, but as a parent also, they are quite interested in knowing how their baby is going to fare in the long-term outcome. Now, if the baby is asymptomatic, he is predominantly going to do well because there are only 6% chances that there will be some impairment. Whereas if the baby is symptomatic in the form of seizures, then there is a 50% chances that the baby is going to have impaired neurodevelopmental outcome. Also, the risk increases with the recurrence. That is, if the episodes are more than 3, then the baby is more likely to develop impaired neurodevelopmental outcome, and the risk increases to 40% if there are 7 or more recurrences. That is a blood sugar of less than 47 for more than 7 days. Again, a high risk of subsequent neurodevelopmental impairment. Now, broadly to remember, bad prognostic factors are if plasma glucose is less than 45 to 47 milligrams per deciliter on 3 or more occasions. Again, is an important bad prognostic factor. Symptomatic hypoglycemia, especially if it is in form of seizures, again a bad prognostic factor. Hypoglycemia in a baby who is preterm or small for date is going to cause more injury in such babies compared to a hypoglycemia occurring in a term baby, because these babies have otherwise additional risk factors which predispose them to impaired long-term neurological impairment. Once these babies have symptoms or they have prolonged hypoglycemia, they can have issues like microcephaly, intellectual impairment, cognitive impairment. They can develop certain disorders like attention deficit hyperkinetic disorder, ataxia, or they can have epilepsy. Therefore, a patient who is symptomatic or has prolonged hypoglycemia should be in your follow-up even beyond infancy and should be looked up for these problems. Now, when to do an MRI in such babies? Any baby who is having prolonged hypoglycemia or is symptomatic should have visual testing as well as MRI of the brain done as and when baby is stable. We'll discuss a case which was quite challenging, and this was a term baby who was 2.75 kgs, AGA, female. AGA is important because, as we discussed, that HG and LGA in itself is a risk factor for hypoglycemia. So always do an anthropometry and chart the centiles. Baby was born by LSCS, so we expect some delay in feeding if the baby is born LSCS. There was no asphyxia. Again, asphyxia is a risk factor for hypoglycemia. It was a non-contiguous marriage. Baby was feeding well on breastfeeds. However, on day 3, this baby had lethargy. He had reduced feeding. The parents continued at home, and finally this baby had seizures also, and then they went to the local hospital where he was admitted with features of shock, poor respiratory efforts, and was intubated. Just like any sick baby, a blood sugar was done and the levels were quite low. So this baby had problems of seizure, hypoglycemia. He was treated for sepsis, although the sepsis screen and the cultures were negative. He was initially treated with IV dextrose, but the hypoglycemia persisted. So he was given a trial of 3-4 days of steroids, and steroids did not help. So it was tapered and stopped, and diazoxide was started. And finally, we had to start octreotide in order to achieve euglycemia. For seizures, we started with phenobarbital, and since the seizures were recurrent, we had to start with an additional drug of phenytoin. He had some jaundice, not very significant to cause brain injury, for which he was given 1 to 2 days of phototherapy. And baby continued to have intermittent episodes of hypoglycemia. On examination, baby was jittery, he was lethargic. There was no state-to-state variability. However, there was no obvious cranial palsy. He had a flexed posture. There was a significant head lag, extension hypotonia. There was clonus, and morose was exaggerated. And on crying, a shrill cry was observed. Subsequently, his anthropometry was normal, as discussed. Head size was normal. His vitals were stable, and he was euthermic. Now, remember the workup which we discussed previously. If we put this patient into this chart, so since this patient was having hypoglycemia which was persisting beyond 7 days, so he fits into our definition of persistent hypoglycemia. So we sent a critical sample when the sugars were less than 50, which was blood gas, beta hydroxybutyrate, free fatty acids, and insulin. However, gas was normal. There was no acidosis. So it takes out gluconeogenesis and other metabolic disorders out of the equation. So what we observed that his insulin was 6. However, he had normal free fatty acids and beta hydroxybutyrate. Now, how to differentiate if this test is done on day 6? Now, how to differentiate whether it is transitional neonatal hypoglycemia or it is genetic? First of all, look at the baby and look for any obvious dysmorphism. If there is obvious dysmorphism, then there is more likelihood of this baby having genetic hyperinsulinemia. Family history, if there is a family history of congenital hyperinsulinemia, again that goes in favor of genetic hyperinsulinemia. Other factors which will help us in labeling this patient as genetic disorder is that if the duration remains more than 7 days and GI requirements remains high, that is more than 10 to 12 milligrams per kg per minute, and baby has normal ketones. If the baby has transitional neonatal hypoglycemia, the body tries to compensate by increasing the ketones. So if there is increased ketones, it is more in favor of transitional hypoglycemia. So this baby was having genetic disorder of congenital hyperinsulinemia, and this baby was continued to require high GI requirement of 10 milligrams per kg per minute along with diazoxide and octreotide. Now, how such babies can be further worked up? A PET dopa, if it is available in house, can be done, but if it is not available, it is not an emergency. So only patient should be shifted if he is stable. Otherwise, the patient should not be stable just for the sake of doing a test. We can diagnose the condition by genetic workup. The genetic workup has to be sent for both the parents as well as the baby. And if the patient is not responding to high GIR, diazoxide, and octreotide, there is a drug known as sirolimus, which is a bone marrow suppressant, can lead to high risk of sepsis, but it can be used for a short term to tide over the crisis till the diagnosis is established. And finally, we have, once we do a PET dopa or if we do a genetic testing, we have to, these babies either have a focal disorder or a diffuse disorder. For focal disorder, the prognosis is good. 80 to 90% of the babies, they do well with resection. Whereas if it is diffuse, then almost all of the pancreas has to be taken out, and these babies have to be then supplemented for various endocrine problems arising due to absence of pancreas. My take-home messages from this presentation is that we should screen high-risk babies and develop a protocol which is followed strictly by one and all. We should ensure early skin-to-skin contact and breastfeeding. Once we do a screening test with glucometer, we should always confirm hypoglycemia with a lab value, but please don't wait for the value to come for starting treatment. GR charts and diazoxide should be available in each unit because you never know when a baby can come with hypoglycemia. It may be in the middle of the night and there may be no doctor or resident available. So even a nurse should be good enough to start treating a patient or a baby with hypoglycemia. Please avoid giving boluses in asymptomatic hypoglycemic babies. If a baby is hypoglycemic beyond 2 to 3 days of life, please do not attribute it to decreased feeding. Decreased feeding is an unlikely cause of hypoglycemia beyond first 2 to 3 days of life. Always admit such babies and work up those babies. Suspect persistent hypoglycemia early in babies who are syndromic or have family history of congenital hyperinsulinemia. Thank you.
Thank you, sir, for such a crisp talk, and I'm sure most of the doubts are dispelled, and you have given us many take-home messages and warned us against the many pitfalls which we do. There are some questions there in the chat box, which Dr. Shubha wants based on MRI.
I lost your voice in between. Can you please repeat the question?
A prognostication of hypoglycemia based on MRI findings.
I did not take MRI into consideration because it is always important to do clinical prognostication before jumping to the MRI. Remember that an abnormal MRI is bound to increase the risk of neurodevelopmental impairment, but a normal MRI does not rule out that the baby is going to be fine. So if there is abnormal MRI, that is a bad prognostic factor, but a normal MRI does not rule out an abnormal baby.
Then one question by Dr. Sudhi: why hypoglycemia is so much harmful to the brain? Why there are more chances of brain damage?
Just like if we starve ourselves and do not eat food, first we'll become lethargic, then we'll be restricted to our rooms, and finally, there was a recent sad incident in one of the premier hospitals of the country where a resident doctor died of hypoglycemia. Similarly, if the brain cells, they are deprived of the food which they eat, which is glucose in the real sense, then these neurons will initially have some impairment, and if the insult is prolonged, protected, then they will die. And once the neurons die, a part of our brain dies, and with that dies the function that it was supposed to do.
Then Dr. Ashadur has a long question which has 3 parts. So I will, part 1 is, can you put some lights on long-term correlation between symptomatic hypoglycemia with MRI findings?
As I said, that the MRI has a good positive predictive value that if it is abnormal, the baby is likely to be abnormal. But whereas it has a low negative predictive value, that is, a normal MRI does not rule out an abnormal outcome. Also, these babies have to be followed up for a long time. That is, now there was one study which was known as child study. They had initially published results of 4 to 5 years. Now they are going to publish in the next month or so the outcomes at 9 to 10 years. So these babies have various abnormalities in the form of arithmetic mean. They may not be having problems in the cognition, but there are other minor abnormalities like attention deficit hyperkinetic, arithmetic mean, scholastic performance, which has some impairment. And the problem with these studies is that there are various factors apart from hypoglycemia which predispose a baby to impaired neurodevelopment outcome. So taking out other factors and attributing every insult to hypoglycemia is again a challenging unless and until we do an RCT. And as of now, there are no randomized controlled trials where we can compare hypoglycemia with euglycemic babies. We have only observational studies.
Second part of his question is recent advances or drugs for recurrent or resistant hypoglycemia. You have mentioned one. So any other recent advances or drugs?
Sirolimus is one such drug which has shown a promise, but again, it should be used as a short-term outcome. The patients become euglycemic, but they can come with a fulminant sepsis, and that can be life-threatening. So once the patient is in hospital, you can start with sirolimus till you are sure about the diagnosis. But sirolimus, although there is one study from Rainbow Hospital which has shown that it is a good drug on small term basis, but the other experience from centers who have used it in long term for months together, majority of the babies, they die off not because of the hypoglycemia or the other disorder, but because of the complication of this drug, which is fulminant sepsis.
Okay. And then the third part of his question is, any concern for asymptomatic hypoglycemia for long-term outcome?
Again, as I said, that there is no correlation between symptoms and blood sugar levels. A patient can have a blood sugar level of 20 and still be asymptomatic. So it is the level, that is the severity of hypoglycemia and the duration, which is important rather than the symptoms.
Yes, so another question is how you pick up cortical blindness in your units and manage them subsequently.
Well, cortical blindness is when can be picked up early when the patient fails to have eye contact and follows an object. And again, these babies, they do not depend on one examination. Right from the NICU when they are getting discharged, they should be followed up in the endocrine department, eye department, hearing assessment, and then a physiotherapist. All have to come together to treat these babies, and they have to be under regular follow-up. One examination is normal does not mean that this baby is going to be normal.
Another question is by Dr. Sandeep. What if a neonate start accepting feeds in a required amount, but goes to hypoglycemia while on GIR age, while we are trying to reduce the GIR after 24 hours of euglycemia? Can we give EBM with 10% dextrose?
Remember that if your dextrose is not working through IV line, it is unlikely to work through the GI line. Other thing is that if you are tapering the GIR and patient develops hypoglycemia, then you should go back to the previous GIR and continue that GIR for another 12 to 24 hours.
Another question from Dr. Veronica is, any cutoff difference in term or preterm in routine definitions?
As I again said that we have stopped following a single number and we follow a operational threshold. In the first 24 to 48 hours, whether he's term or preterm, although it is one of the factors which should decide the cutoff, also it depends on the other associated conditions. That is a preterm who is otherwise normal versus a preterm who has other additional risk factors like asphyxia, polycythemia, or sepsis. The cutoffs cannot be same. In a high risk, whether he's preterm or term, if he is high risk on IV fluids, has additional risk factors, it is better to maintain a level above 60. Whereas in an otherwise healthy preterm baby, you are good to maintain levels above 47.
Dr. Veronica also want to ask, like, the terminologies prolonged hypoglycemia and persistent hypoglycemia, are these synonymous?
Well, they are interchangeably used for the same definition, that is either GR of more than 10 to 12 milligrams per kg per minute or requirement of, that is hypoglycemia persisting beyond 7 days of life. However, the basic aim of this definition is to pick up congenital hyperinsulinemia or syndromic babies. So that is the main aim. But whether you define it as persistent or prolonged, that is not important. What is important is to pick up babies who have congenital hyperinsulinemia or who are syndromic early, because these babies will have recurrent episodes of hypoglycemia. If you start screening them for hypoglycemia, suddenly these babies can crash and have severe hypoglycemia and resulting to long-term neurological impact. That is the main function of this definition.
Yeah. And Dr. Kirti wants to know, in preterm, how long to continue RBS monitoring, how frequent? Any guidelines?
Again, preterm babies, if they are on full feeds, initial 48 to 72 hours is enough. Whereas if these babies continue to be on IV fluids or TPN, then they should be continued to monitor either once or twice daily, depending on their sugar levels, till they are on full feeds.
Dr. Shekhar wants to know that is dextrose gel available in India, and if yes, by what name?
You can buy it from Amazon. It is freely available.
Dr. Deepa wants to know that after LACS, if mother is not able to feed the baby, which is good, giving milk from different mother or formula milk?
There is no doubt that first choice is mother's own milk. Second choice is express milk, breast milk from own mother or some other milk, and then only you should consider formula.
Dr. Veronica has posted the question, any clinical differentiation in secondary microcephaly from hypoglycemia compared to that seen with severe asphyxia and HIE?
Please repeat the question.
Any clinical differentiation in secondary microcephaly as a result of hypoglycemia compared to that seen with severe asphyxia and HIE?
In severe asphyxia or HIE, the pattern of the injury, because with microcephaly, if it is a preterm or a term baby, there will be truncal hypotonia associated. Whereas in hypoglycemia, will be just a microcephaly or associated with or without cortical blindness. There is no cortical or truncal hypotonia. That is pathognomic of asphyxial brain injury.
What concentration is the dextrose gel, and does it lead to rebound hypoglycemia?
It is available as 40% dextrose, and it is given in the dose of 0.5 ml per kg or 200 milligrams per kg. There is whatever literature is available as of now, there is no rebound hypoglycemia or hyperglycemia associated with dextrose, because you are not giving it through IV, you are giving it orally through buccal route. So it is slowly absorbed, leading to slow persistent rise in glucose.
And the last question from Dr. Kirti is, can we take jitteriness or lethargy as symptomatic hypoglycemia?
Definitely yes, but one should remember that jitteriness can be a normal feature in first 24 hours of life. So if the baby is jittery, kindly check his sugar levels, and if they are low, treat him as hypoglycemia.
More questions have popped up. What is the indication of dextrose gel?
Although not supported by our bodies like IAP and NF, there are various international bodies like New Zealand Pediatric Society, where they have incorporated this dextrose gel as a form of treatment. That is, as soon as the levels of sugars are low, they start with the oral dextrose and then go to IV fluids. However, if it is severe hypoglycemia, it is not going to get corrected with buccal dextrose. It is only for levels who are borderline or mild hypoglycemia that buccal dextrose has been used. As of now, we still do not have concrete evidence. That's why it is not being taken up by majority of the bodies around the world. But there are some international guidelines where it is a part and parcel of the treatment of hypoglycemia.
Many of the listeners have asked that please share your slides, and some of them wants to know how to calculate GIR again.
I will send we have few articles on hypoglycemia. I will share that in the group along with how to calculate. I will make it sure it is there.
I think we would have to stop questions, Dr. Nitika, if you allow. Okay, all right. I think it's a time to wind up because otherwise Lakshmi will just close the session. I'm worried. Be rest assured that whatever questions are there, or if they are left, 100% of them will be answered in the next group. So please keep posting your questions. It is our guarantee that we shall respond to all the questions. Now, I'll just make some remarks before I thank. First, in neonatology, no baby under your care should become symptomatic due to hypoglycemia. It is absolutely preventable. And therefore, your level of observation and prediction should be very high. Because if he develops symptomatic hypoglycemia, he is going to develop some degree of brain damage, whatever it may be. It means that you have made a baby brain damaged under your care for a situation which was preventable. That should be very clear to all of us. Secondly, all these definitions are only for the sake of analysis data. But if the baby has become symptomatic and if you say his blood sugar was 45, he has become symptomatic. And therefore, we should err on the side of keeping a blood sugar on a safer side. In my entire life in practice, I have kept a diagnostic limit of a blood sugar of 50 for all the babies, 50 or more. If baby is having a blood sugar less than 50, go in active mode, don't wait. And that is why when you look at our therapeutic algorithms, even WHO, whatever it made earlier, we did not agree to that. And that is why we are therapeutic algorithms which are current and more we are going to write. We would say that please maintain blood sugars above 50 milligram percent or maybe above 60 milligram percent. Don't let it go down. And if a baby becomes symptomatic, I use a very strong word that we are criminally responsible for making this baby symptomatic and damaged in long term. So this should be clear. The second thing which I would like to make clear is that IV line is just IV line, but gut line is the best line. And therefore, use gut line most optimally, whether you are preventing hypoglycemia or treating hypoglycemia. It must go on simultaneously, concurrently, adequately, effectively. Now, whatever it takes, please do it. You shall never run into problem if you are using your gut line, but you have stopped gut line and then you are just treating with IV line. Be ready for more complications, be ready for more pricks. So gut line must continue unless and until there are contraindications for gut line. Remember that. Then Akash has told in detail, but I'll just mention one or two investigations which have been frequently asked. Now, MRI changes and other changes. What I want to bring out is basically that in hypoglycemia, the parietal and occipital cortex are affected, and hence there is affection of the vision. And therefore, when we are looking for investigation, in addition to MRI, of course, MRS one can think, but please do think of a visual evoked potential and SSEPs, especially those who are postgraduates or those who are DMs sitting here should always think of doing evoked potentials in the case of hypoglycemia. Hope Akash will agree with me. And the other thing is that whenever we have a hypoglycemia, it is good to diagnose, but please start your early intervention. You must consider this baby as a potentially damaged baby, and hence go all out to fully prevent preventable things which this baby may have of any sensation or motor or whatever it is. So early intervention must start without any delay. I think a couple of points which I made, there are more. Honey, we have talked, and maybe when we talk of a dextrose gel, everyone gets excited. But when I talk of honey, nobody, they have many questions. Let us remain Indian. And Akash is smiling, he will start honey, I'm sure. And I may not say so outrightly upfront, but there is a time to consider that can be fortify our milk with things like honey and ensure the safety of that. Otherwise, you'll find sometime later the trial will come when people will use honey and publish, and we'll only wait for them, not we starting ourselves. So with this, I thank you, Akash, a wonderful, masterly talk. You exhausted my question box. So very grateful to you.
Sorry for overshooting the time, but I think this is something which we think is easy to treat and easy to diagnose, but this is the area where we make the maximum mistakes.
Absolutely. It is preventable and criminal if baby gets damaged under your care of hypoglycemia. Similarly, I say for hyperbilirubinemia. For me, both these conditions are identical. So thank you, Akash, for being so great, so wonderful. And my moderator, so sweet and covering everything so comprehensively. And my, the first time fellow, Garima, a good kickstart. And I cannot go without thinking Lakshmi. And I see Manoj smiling, and they are many more great friends. Dr. Sudhir, I can see in front. So nice of you being on board. All the great people are there. So please pardon me, I'm not being able to thank you everyone, but indebted to you. So my audience, so nice of you. Please keep attending more and more. Today, Akash, credit goes to you. You took up our audience today on a higher side. We crossed 80, I suppose. So with this, wish you all good luck. Hope to see you next time. Thank you, everyone.
Good night, sir.
Thank you, all the Netsu family.
Thank you so much for the wonderful talk.
Good night.
Bye-bye.
Good night.
Thank you, sir. Thank you for joining.
Bye, Akash.
Thank you, sir.
Good night.